Hi everyone, I am Dr. Himadri. Let's talk about empyema today. This is very important topic. So what is empyema? By definition, empyema is collection of pus within the pleural space or within the pleural cavity. That is in between the visceral pleura and the parietal pleura, there is collection of pus. This is called as empyema. So before understanding the empyema by pathogenesis, I would like to discuss here about the sequence of events that actually happens in case of empyema. Okay, so in this photo what you can see, there is multiple alveoli, and within this alveoli there is inflammation in the alveoli as well as in the surrounding tissue, so we call it pneumonia. So in case of empyema, the initial event that basically triggers is usually pneumonia. If the pneumonia is present in the subpleural space, that is just beneath the pleura, there is, because of this inflammation and the local cytokine release, there is collection of fluid within the pleural space. That is the, because of cytokines, your inflammation triggers, and eventually there is dilatation of blood vessels in the subpleural space and collection of fluid within the pleural cavity or within the pleural space. Also it actually happens in association with underlying lung infection, that is lung pneumonia. So we call it parapneumonic effusion. Okay, parapneumonic pleural effusion. So this is parapneumonic pleural effusion. So after parapneumonic pleural effusion, what happens? As the inflammation keeps on going, more amount of fluid escapes those spaces and eventually accumulates within the pleural space. Okay, as well as few neutrophils, very few neutrophils also jumps from these blood vessels and come into the pleural space. So this is called as uncomplicated parapneumonic effusion. Okay, as it is called uncomplicated because there is collection of fluid and very few neutrophils, but no bacteria is present. Therefore the fluid is totally sterile in this at this time. So we call it uncomplicated parapneumonic effusion. Okay, now as the time passes by, what happens? More and more amount of bacteria. Now initially there was no bacteria. Now in this phase, bacteria basically jumps into the pleural space, and to tackle with those bacteria, to fight those bacteria, neutrophil also jumps into this place within the pleural space. So now this becomes complicated. The uncomplicated things become complicated by the bacteria and much more amount of neutrophils, as well as there is macrophages and fibroblasts that comes and they deposits the fibrin within the pleural space. Okay, so there is septation, few septations are also present. So now this becomes your complicated parapneumonic effusion. So after complicated parapneumonic effusion, in this sequence we have the actual empyema. So what happens in this case? Much more amount of bacteria comes. As the time passes by, more and more amount of bacteria comes into this place, as well as more and more amount of neutrophil, more and more amount of macrophages, as well, and they keep on lying down those fibrins within the pleural space. Therefore a fibrinopurulent material is being formed. Okay, so this is called as empyema. Now this stage is basically termed as empyema. So empyema means fibrinopurulent fluid which is present within the pleural space along with those organisms. May or may not be organisms. Those organisms are basically proven in terms of gram stain or culture sensitivity report. Okay, so this is the sequence of events that actually happens in empyema. Initially parapneumonic effusion, then uncomplicated parapneumonic effusion, then complicated, and eventually forms the full-fledged empyema. Okay, now let's talk about the pathogenesis. Once you know the sequence of events, it's very much easy to understand the pathogenesis, because whatever thing I have already talked is basically the pathogenesis. Okay, so now let's see. In the initial phase, when there was inflammation and because of this pneumonia and cytokine release, only fluid as well as proteins are leaving the blood vessels and entering into the pleural space. We call this as exudative space. That is, in this phase there is fluid as well as proteins as well as few neutrophils. but no organisms, that is no bacteria. Okay. So in exudative phase, the pH is more than 7.3 and the glucose is more than 60 mg per dl, and LDH is less, that is less than 1000. Okay. And it actually happens in within the 1 to 3 days of inflammation or this process. Okay. Now this is called as exudative phase, followed by there is fibrinopurulent phase. What is fibrinopurulent phase? Fibrinopurulent means there is organism, that is the bacteria is present, as well as there is dead or dying neutrophils, dead or dying macrophages, and few septations are also present. So this is basically, if you look with the previous thing we discussed, this is complicated pneumonic effusion plus empyema. This phase is actually fibrinopurulent phase, where the pH is going to be less than 7.2, glucose less than 40, and LDH is more than 1000 international unit per liter. Okay. So after the fibrinopurulent phase, we have organization phase. Please remember, fibrinopurulent phase actually happens within 4 to 14 days of inflammatory process. Okay. And in the last phase is the organization. What is organization? Organization means more and more amount of fibroblasts are going to come, and they lay down the fibrin strands within the space, so that whatever fibrinopurulent material is present are going to get entrapped and get organized. So this is called as phase of organization, that usually happens more than 14 days of inflammation. Okay. So this is basically because of this entrapment, the visceral pleura and parietal pleura cannot move separately. They becomes connected by those strands. Okay. So there are three phases: exudative phase, followed by fibrinopurulent phase. After that there is organization. So 1 to 3 days, 4 to 14 days, more than 14 days. Okay. Okay. Now once you are done with the pathogenesis, now I would like to move forward to the clinical features. What you will find in this patient. Okay. The usually, the patient admitted and patient had pneumonia, and we started antibiotics. Patient received antibiotic for 48 hours, but still there is no such improvement in this patient. So that means there is persistent high grade fever. Still there is respiratory distress in the form of subcostal retraction, intercostal retraction, and the patient is sick, the child is sick. And on examination, what you will find? You will find there is reduced air entry in that site of pneumonia, side of empyema. Along with the dull, the node becomes dull on percussion, and on auscultation you will get bronchial breath sound and full of crepitations. Okay. And this basically suggests that, as well as the patient is very sick, that means probably there is some complication of the pneumonia that has already happened. So what you would like to do? Few investigations. Okay. Before investigations, let's discuss what could be the probable organisms in this case. If the patient is immunocompetent, mostly the organism would be Streptococcus pneumonia or Staphylococcus aureus. Please don't forget Staphylococcus aureus. It may be methicillin sensitive, or could be methicillin resistant, or could be vancomycin resistant. Okay. If it is hospital acquired, please remember the organisms are mostly methicillin resistant or vancomycin resistant, or maybe pan resistant organisms. Okay. In case of immunocompromised individuals, what could be the organism? It could be Klebsiella or it could be Pseudomonas. These are mainly gram negative organisms, and in few cases we can have fungal infection as well. Okay. So we are done with organisms. Now, as we were talking, the clinical approach to this patient. So once the patient is very, very sick, we would like to investigate. So complete hemogram, CRP, electrolytes, serum albumin, serum total protein, LDH, these are commonly done. And what you will get, there will be neutrophilic leukocytosis in the blood. Okay. And CRP will be raised, procal will be raised, like that. And pleural tap is done. Initially there could be diagnostic tap, but if the amount is more by that you have confirmed by USG, please put the ICD intercostal drain. In the USG, what you will find? Multiple septations. Okay, we will discuss. Please wait a bit. And what we can do? HRCT thorax. Okay, that is high resolution thorax, CT thorax. Okay, HRCT thorax. So now let's talk about the chest X-ray. What you will find in this patient? What you can see? There is left-sided whiteout lung. What could be the differential diagnosis for left-sided whiteout lung? It could be pleural effusion, it could be collapse, or it could be consolidation. So can you differentiate from this picture? In all these three conditions, there will be left-sided or there will be unilateral whiteout lung. Okay. So how to differentiate in case of pleural effusion? Look, in case of pleural effusion, as there is collection of fluid in the pleural space, there will be mass effect, and also the mediastinum will be shifted to the opposite side. Okay, the mediastinum, that is the, please look at the trachea, it will be shifted towards the opposite side of the whiteout lung. But in case of collapse, it will draw or it will drag the mediastinum towards its side. Therefore, there will be pulling of the mediastinum towards the same side in case of collapse. But in case of consolidation, the trachea would be in the midline. There will be no shifting. Along with, you will get air bronchogram sign. Okay. Now let's see in this picture what you can see. Look, there is whiteout lung in the left side, but the mediastinum being shifted towards the right side. What that means? There is left-sided massive pleural effusion. Okay. Now in this chest X-ray, look what you can see. A patient is standing, but still there is those white opacifications present at the left side, and also the CP angle, that is costophrenic angle, is being obliterated. There means what? There is fluid collection, and this fluid is organized, and there is presence of septations. That's why there is position change. The patient is standing, still the fluid is present in that shape, what you can see. So this is empyema. In the HRCT, you can see in the mediastinal window, in between the visceral and the parietal pleura, there is collection, as well as in the lung window, you can see there is in between the visceral and parietal pleura, there is collection, and this is empyema, as well as there is left-sided pneumonia present as well. You can see few air bronchogram signs as well as few consolidations. Okay. Now what it is? This is USG lung. Okay. So in between the visceral pleura and the parietal pleura, there is widening or gap, you can see. Okay. That means there is collection of fluid, and what I have already marked, there is loculations, there is multiple fibrins, and they are basically forming the septations. So this is empyema. In the USG lung, you can find empyema. Okay. Now let's talk about the treatment part. What will be the treatment? In case of stage 1, if the disease process is at its initial phase, in the stage 1, what would you like to do? Yeah, initially please give antibiotic to this patient. Antibiotics are essential, and intercostal drain may be given, may not be given. That depends upon the amount of fluid which is present within the space. If it is less, please don't give. If it is more, please put the ICD. In case of stage 2, when there is fibrinopurulent material is already present, you have to give antibiotic, as well as you have to give intercostal drain. Why? Because if you don't give intercostal drain, patient is not going to improve. Okay. Plus minus VATS, that is video assisted thoracoscopic surgery. But in case of third stage, that is organization, there is no other option, only VATS, or we can have mini thoracotomy. Okay, or maybe decortications, like that. Okay. So there are 3 stages: stage 1, stage 2, and stage 3, and we have treatment modalities we have already discussed. We have already discussed stage 1, stage 2, and stage 3 treatments. Please recap once again. Stage 1, antibiotics plus minus ICD. Stage 2, antibiotics plus ICD, and within the ICD you need to give fibrinolytic substances. Okay, we will discuss about it. What are fibrinolytic substances? And stage 3, there is VATS or mini thoracotomy. So now let's discuss what are the antibiotics, choice of antibiotics. Mostly it could be Streptococcus pneumoniae or Staphylococcus aureus. In case of MSSA, methicillin sensitive, you have to give ceftriaxone plus cloxacillin or flucloxacillin. Why? Ceftriaxone having both positive negative coverage, and cloxacillin for methicillin sensitive. Okay. But why you don't give methicillin? Because this causes interstitial nephritis. In case of MRSA, ceftriaxone plus vanco. In case of VRSA, we give ceftriaxone plus linezolid. Please remember this. Okay. And now the concern is, what is the duration? Duration is mostly in this case, because these are basically complications, we need to give it for at least 1 month, 2 to 4 weeks. We make an increase up to 6 weeks. Initially the IV is given. As the patient improves, we can shift it to oral and can discharge those patients. Okay. And another thing, if there is associated soft tissue infection, you need to give anaerobic coverage. Okay, clindamycin is given. It has both anaerobic coverage as well as PVL neutralization property. PVL means pentonvalent leukocidin, which is a toxin which is being produced by Staphylococcus aureus, and clindamycin does neutralizes. Therefore, we can use clindamycin as well. And apart from antibiotic, what else you want to do? Please give supportive therapy like like IV fluid, and also paracetamol, as the patient who could be having fever as well as pain, and pantoprazole. And in case of respiratory support, please don't forget, if the patient is having subcostal intercostal retraction, need to give oxygen therapy or PEEP support in the form of NIV, or the patient could be ventilated or intubated. So where to put those ICDs, intercostal drains? You need to know the triangle of safety. It is basically lateral edge of pectoralis major, base of axilla, and lateral edge of latissimus dorsi, and in 5th to 6th intercostal space. In this photo, you can see the ICD is given in the right side, as well as in this photo in the right side. Okay, so now few words about the indications of ICD, where to give in case of pneumothorax, or in case of empyema, massive pleural effusion, hemothorax, or hydrothorax. You can give ICD. When you know the indications for ICD, you must know when to remove ICD as well. Okay, so if the drain output becomes very less, that is less than 1 to 2 ml per kg per day, or less than 10 to 20 ml per day for 3 consecutive days, as well as the patient is improving clinically as well as radiologically, we can consider moving out or removing the ICD, intercostal drain. Okay, once the ICD has been put into place, fibrinolytic therapy should be started, because and before giving fibrinolytic therapy, you must know what are the contraindications of fibrinolytics. Okay, contraindications are like bronchopleural fistula, because in bronchopleural fistula can happen in case of necrotizing pneumonia caused by the Staphylococcus aureus. Okay, so the contraindication is bronchopleural fistula. Another contraindication is thrombocytopenia, that is low platelet count, because if you are giving it, the patient can bleed. Okay, in case of streptokinase, less than 1 year, dose is 10,000 unit per kg, more than 1 year, 20,000 unit per kg, dissolved in 50 ml of NS, given in 1 hour duration. Then it is blocked by the clamp, that is the mosquito. It is kept for 4 hours, then we remove it. Okay, that is we remove the clamp, and usually given twice a day for 3 consecutive days. And we have urokinase as well, and you can see the dose of it. The main function of it is basically to break down the septations. And here you can see the photo of VATS is going on. Thank you.